Yes,
Yes,
sir.
sir.
Yeah. To start with, my given topic was robot as a biomedical device in orthopedic surgery and rehabilitation. Let me introduce myself. I am Dr. G. Mukesh Mohan, based and born and brought up in Trichy. And to start with, there is a categorical statement which I would like to make. Robotics are here to stay, at least in healthcare. Over the past 45 years, the global population has doubled. And concomitant with this growth, we have experienced an exponential growth in technology. Thereby, the technology is helping the humankind in its day-to-day activities. The term robota, which means a forced labor, is actually coined by a writer, Carol Capek, who has devised an imaginary character and he has devised a robo which actually kills the mankind. But in reality, that too in medicine, the robots are really helping the patients and the doctors. In treating the diseases, the robots can be utilized in all the aspects. Especially, we can divide it into diagnostic part or therapeutic part or preventive part. So what do they do in diagnostics? See, the automatic machine learning process, they can pick up patterns of signs and symptoms and identify the diseases at the earliest. For example, if the patient, if there is a cohort of patients who has a lot of pulmonary symptoms like lung symptoms, if you feed the x-rays of hundreds of patients, and this machine learning process will identify who are suffering from tuberculosis, who are suffering from allergic uh, pulmonary diseases. This machine learning process can expedite the diagnostic process so that the treatment can be started at the earliest, and we can segregate those patients who are at risk of spreading the disease to the other community people. So the huge amount of data which we already have, they can be processed and we can form a protocol to how to treat. For example, in COVID, machine learning helped in identifying the patterns of the disease. For example, in CT scan of the COVID patients, we identified patterns of the involvement of the lung and we gathered them into groups and we divided into 6 categories and we formed a protocol like COVID 1 and 2, we can just wait and observe, but COVID 3, 4, and 5, 6, it needs to be carefully monitored, and especially 5 and 6, they need to be hospitalized. So these kind of protocols are helping the community as well as the doctors. Like in that part, machine learning definitely helps. And other parts are the therapeutic and preventive. Let us see one in detail. Like, so what are the therapeutic application of robots, which is mainly surgical robots? So the surgical robots, which is used in general surgical procedures like urology or ENT surgeries or for the abdominal surgeries, they are mainly to remove the tumors and diseased organs from deep inside the body, which is very difficult to reach by the human hand. For example, if there is a tumor inside the prostate, there is a tumor in the prostate which is situated deep underneath the bladder, which is deep inside the pelvic cavity. So for a human to approach this, we may need to extend our approach incision. We may make it a big cut in the abdomen and we need special retractors to see the organs and then we have to remove it. But with the help of robots, we can introduce a microscope inside the abdomen and we have enlarged vision of that particular organ, and then we can remove it very safely with the least amount of damage to the patient. What is the role of orthopedic robots? See, you all know that what is a CNC robot. The orthopedic robots currently, which I use, is basically a CNC robot. What do they do? The CNC robots actually, they generate a model from a stock piece. Likewise, usually the orthopedic intervention, we need an implant. For example, if there is a joint degeneration, the joint cartilage is already damaged, we need to replace the cartilage with metal. For the metal to sit perfectly into the bone, we need to shape up the bone. Usually we do the shaping process manually, but here the CNC robots, that is orthopedic robots, remove the unwanted bone from the damaged part of our bone, and it creates a recess over which our implant sits very snugly. Okay, right. So orthopedic robots are basically CNC robots, but it is a robot in hand. Right? What are the other ways in which the robots can help in orthopedic people? Like they can be as a collaborative robots or cobots. For example, in a spine fracture fixation, we can pass the screw with the help of robots, preventing damage to the neural structures. Let us see about the CNC robots. The CNC robots basically works on the principle of subtractive manufacturing. Likewise, in orthopedic robots, in total knee and hip replacement, it acts as a CNC robot to make a perfect receiving area for our implant. And lastly, the rehabilitative robots are in the pipeline. So let me just give a broad overview how a joint replacement is made, because you may not understand what is a joint replacement. So here's our picture of our human body. There it shows the pelvis and the hip, knee, and ankle. Basically, if a person is fit and healthy and the joints are healthy, this alignment, like the hip, knee, and ankle, they are all should lie in the same line. This is the normal alignment of our body. In disease process, this alignment can get altered, thereby resulting in accelerated wear and tear of our own joint. So we have to see what is knee arthritis. So arthritis means inflammation of the joint, and especially knee arthritis, it is the degradation of the protective cartilage layer. In each and every joint, there are two bones. The two bones are covered by a whitish, soft, rubber-like structure. It is called as cartilage. You could have seen this in people who are eating non-vegetarians. There will be a soft structure at the end of the bones which we eat. That is called cartilage. So basically the function of cartilage is to provide cushioning to our joint so that it reduces the wear and tear of our body. If the cartilage is lost, the alignment of the limb will be lost. So the patient may have pain, swelling, difficulty in moving the joint, as well as restriction of movement. The basic causes of wear and tear are obesity or previous trauma, or sometimes patient can have this degeneration de novo. So what is a knee? See, the knee is a structure which is made up of thigh bone and our leg bone. So both these bones join together to form a knee joint. Okay, and this is the cartilage layer which protects our joint. Basically, if you compare the joint to a vehicle, the cartilage layer are to be considered as our running tires, right? So there are, in both our knees, we have 4 tires basically, which protects the joint. Also, it gives lubrication, as also it gives mobility in a fast manner. If something happens to the layer of your tire, what happens? It gets worn off. It is as simple as that. Like if the threads in your tire goes off, it means the tire is not usable. Likewise, the cartilage is lost. It means degenerative osteoarthritis or wear and tear has occurred on that joint. This is the loss of cartilage. So this is our basic walking pattern. See, if you carefully observe, the center of the body has to pass through the ankle, knee, and also the hip and through the spine. If something happens to our joint, what happens? The center of the body, the weight axis will not pass through the center of the knee. It will pass to the inner side of the knee, causing a varus deformity or a bowing of your legs. This elderly lady has a wear and tear of our knee joint. See what happens? She is having a very gross deformed knee. She's having a bowing of the knee, causing a lot of pain and difficulty. If you could see the X-ray, see the thigh bone and the leg bone will show a gap. That means the cartilage is intact. But here, when we compare it, the cartilage gap is lost. That means the joint is already worn off. If the process is not treated at the right time, it will go on progress to the severe stage of complete bowing of the legs. Here, the hip, knee, and ankle are entirely deranged. They are not in the straight line. But after surgical correction, if you could see the hip, knee, and ankle are aligned at the same line. That is the role of an orthopedic joint replacement. Coming to the point, so how does the joint look like after our replacement? Here you could see the lower end of our thigh bone and the upper end of the leg bone are replaced by a metal. And in between those, we are placing a highly cross-linked polyethylene layer which acts like a cartilage. Also, it gives smoothness as well as lubrication to the new artificial joint. So the goal of our surgery is to create a joint with good amount of space as well as alignment. So this is our goal of a joint replacement surgery. How the robots are going to help the doctors in achieving our goal. So coming to the principles of surgery, say what do? We remove the old damaged part of the cartilage and we will freshen up the underlying bone and we will put the metal cap over the underlying bone. It is similar to a retreading process where we will remove older threads and buffed up the underlying tear and repaste a new thread. The knee replacement is just similar to a retreading process. But will we do a manual alignment for our cars? No. We all want a computerized alignment. Why? Because we believe more about the data. We need to see the numbers. What is the exact alignment? What is the exact difference between both the tires? And everything is computerized. So we believe computerized alignment even for our cars. Then why not for our own patients and our relatives? So conventional versus robotic joint replacement, when we compare in the manual method, we need to size the joint, plan the gap, do the bone cuts, release the soft tissue and analyze it, everything by manual. That is by our eyeballing method. 99% we were doing right and so far so good. But sometimes 20% of the people are unhappy after total knee replacement because of maybe there could be errors in the sizing or planning of the gaps or during the cutting process. So all these important steps have been automated as well as guided by our robotic technology, which is a very handy tool in our hand. It is a combination of navigation, executing and cutting tools. So again, as I said earlier, like to put the processes into the damaged bone, we need to freshen up the bone. For that, we need to take a front cut, back cut, and the lower cut, and also the upper oblique and the lower oblique cut. So these cuts are done usually by our manual means. See, if you cut the bones in a perfect shape is the reverse molding process, the implant will fit the bone very snugly and there will not be any overhanging or there will not be any further damage to the bones. So this is a example of how a manual replacement is being done. We will be putting a long rod inside our thigh bone and put a jig and cut the lower cut, and we put another jig and we will measure the size of the bone, what is the size of the particular femur, and we put another jig to remove all the anterior cuts, upper cut, lower cut and oblique cuts and everything. So these will be done entirely by manual method, and the lower part of the bone is also removed by our manual jigs. Once we do that, we will analyze whether the inner side of the ligament and the outer side of the ligaments are completely balanced, and how is the joint, whether it is too tight, it is too loose, and it is stable throughout the joint motion or range of motion. Everything is analyzed manually. So this is how a manual method is used. We use a saw and cut the bone from the damaged part. So this is an example of how a conventional replacement is done. We remove the layered bones, one and all, and then we put the trial processes and we put the final processes. How robotics is helping here? See, here is an animation of our robotics where trackers are being placed in the thigh bone and the leg bone, and the trackers are relayed to a lens, to a camera. The camera will feed the data to the robotic machine, and through a special stylus, we will generate a 3D model of your thigh bone as well as your leg bone. And we analyze the movement of that particular joint, and it will show how tight the joints are and how loose the joints are, and what is the exact size of the implant for that particular patient. These are all which can be modified, and it gives a color coded region. Like what is the, if you could see, so this is a color coded region of our patient's bone, where these are the regions which needs to be removed by our robotic burr. So it will not act any other area other than these color coded regions. So if the burr will be activated and the burr will start removing the color coded regions, and then we make a pilot hole in the distal femur and then use a special burr to cut the upper bone. And once we do that, then we analyze how is the joint fitting, what is the tightness in the medial side of the joint, what is the tightness in the outer side of the joint. Everything is given graphically to us so that we can put the final implant once we are all 100% satisfied. This is an example of our real-time example where I use a special stylus to generate a 3D model of our thigh bone, and it takes only half a minute to 1 minute time to generate a 3D model. And we usually have a special stylus and lid, and it also marks the front portion of the bone, like whether you are going off the limit, whether you are inside the limits of the work. So these special points will give us a warning signal whether you may not go, you are going outside the joint and all. These are all the inbuilt safety features available in this system, and this is the 3D mapping of our leg bone. So once we map both the femur or the thigh bone and the leg bone, then we analyze what is the size of the prosthesis, what is the size of the implant this particular patient needs. Once we finalize the size of that, then we freeze that size, and the machine will automatically register the size of that particular implant for the patient. Once we do that, then we can analyze the tightness of the joint, whether it is very loose or very tight. So here you can see the size of your femur and size of your tibia and what is the thickness of your polyethylene we are going to use. And we can see this is a special point, one notch indicator. It shows if the implant is moved front and back, you may likely to cause damage to the native bone. So the machine will automatically give an alert to us. So there is no chance of making an error and causing undue damage to our patients. So once we finalize the size, then we freeze it and then see what will be the size, what will be the cut surface if I take up this particular plan. If I am not happy with this plan, I can always modify the plan. And this is your assessment of the gap of the joint. It shows the baseline is the neutral, and whatever seen beneath the graph is the tightness, and whatever seen above the graph is the laxity or the looseness of the joint. See, we mean what is our plan? The goal is to give a stable joint, and our graph should be just above the graph midline. So this is a mapping, 3D mapping of our tibia, and this is a 3D mapping of our femur bone. So once we complete it, then we go to the next stage, right? So having done that, we reach this stage and we can choose the size of the implant which is suitable for that particular patient. And we always take a full length view of a full length X-ray of our patients, which shows the alignment of our limb. Here it shows this patient is having a 190-degree deformity. Instead of 180-degree, it is 190. That is 10-degree deviation is there. Here in the right side, almost like 4-degree deviation is there. The goal is to restore this alignment nearing 180. We may not reach 180. Sometimes we may err on 1 or 2 degrees. That is okay. But we have to be very close to the 180 degrees. This is our pre-op alignment, and the machine will give a data that what is your post-op alignment. I am choosing a 0-degree valgus. That means I am planning to recreate an axis of 180 degrees, right? So spontaneously, immediately, the machine gives a 3D image of the particular patient's bone as well as the implant overlap. So I'm going to just match the size of the implant over the existing bone and see whether I'm happy. If the front portion of the implant is just protruding, then I can push it backwards. Likewise, I can push it upwards, I can push it downwards, as well as I can rotate the implant in either way. So these steps are being done before doing the actual surgery. These are all pre-operative planning, doing the surgery itself, and then no damage has been done until we freeze the plant. So once I am satisfied with the surface area, like this, the image is shown by the computer that this will be the cuts if you do the plan as per you have registered. Once I feel that this plan is okay, then I will finalize it and then I will proceed to the next step. And then comes your gap assessment state, that is the tightness of your joint. Here the real-time patient shows the graph is beneath the baseline. That means it is very tight. Then I have to loosen up the joint a little bit by means of soft tissue releases as well as the planning of your implant. The implant can be adjusted either upwards or downwards. Likewise, we can plan the surgery beforehand itself. Also, the machine gives a color-coded images like this. It shows that having selected a size of around 9 mm resection, that I want to remove 9 mm of bone from the lower end of the femur as well as the upper end of your tibia, then the machine will automatically give a color-coded image. What does that mean? Like I need to remove the color-coded regions from the bone by means of our robotic burr. So let me show the real-time example. So here I'm using the robotic burr, which is a very handy tool in my hand. I'm just trying to remove the color-coded regions. As I keep on removing the bones, parallelly the screen will show that I'm removing the color one by one, the magenta, blue and green. Once I remove all the green, the white surfaces will be exposed. Then my job will be over. Like the machine will guide us until I remove all the color-coded regions. There is no margin of error in that because it is very precise. If I take the burr out of that region, color-coded region, it automatically stops. So it will not damage your other areas. So once I did all my resections, then I will analyze the joint. I'll be putting the trial implants inside, and then I will take up the joint throughout the gentle range of motion, and I see how is my joint before putting the final implant. This is the trial implant. So once I put the final implant, then nothing can be changed. So when we put the trial implant, I was able to get a graph like this. That means the joint is fairly stable throughout the range of motion until 130 degrees of motion, as well as the joint is 1 or 2 mm lax. We need a perfect graph like this, and the machine will give a data sheet like this, like the preoperatively, what is the deformity and what is the achieved alignment and what is the size of the implant which we have used. Everything is given as a data sheet. What is the safety of robotics? I have opened up my handy robo, which is in the center part, we could see the burr which goes to and fro. And this is an actuator which controls this robo's movement, whether it should go forward or backward. Here you could see when I bring the tip of the burr towards the upper end of the tibia, which is the color coded region, the burr will come out and take up the bone. If I take it away from that particular color coded region, automatically the robo will get retracted inside the sleeve and it will not affect any unwanted areas. So the safety of robotics 100% achieved in this mechanism. So this is the safety of robotics. Coming to the clinical examples, like see here is a very grossly deviated knee. The hip, knee and ankles are completely bowed. So with the help of robot, this is the preoperative range, like the yellow shows is very tight and the violet shows it is very lax. So the one side of the joint is very tight and the one side of the joint is very lax. With the help of robotics, we are able to achieve a perfect balance in the joint. Here we could see the gap between the inner side and the outside is restored and also the alignment is restored. So this is an example of the patient who was very obese as well as he had a very bowed leg. And within a month's time, we did the surgery for both legs at the same time. And she was able to walk independently, that too with the corrected limbs and without any pain on the first month itself. Again, a severely affected lady, she was bedridden for almost like 6 months. She was not, her knees are crooked and she was not able to straighten her legs for the past 1 year. But still, she wanted to have a relief from her condition. Then we planned for robotic surgery. And this is the first day. After doing both surgeries at the same time, she was able to stand up with the help of her team. And within a month's time, she was able to. She had multiple comorbidities. That's why she needed some support too also. Coming to the younger patients, see, if one of your car tire is burst, would you try to change that particular tire or would you try to change all the tires? The similar concept has to be applied in our knees also. See, if one side of the joint is worn out, why should we do a total knee replacement? Why should we change the entire knee? We should concentrate on the worn out part. That is the concept of partial knee replacement or unicondylar knee replacement. See, this is our animation of our unicondylar replacement. What is uni? Is the one, that is one part of the joint which is affected. It will be replaced isolated in an isolated manner. Instead of doing a total knee replacement, we just do the unicondylar replacement or a partial knee replacement. What is the advantage of doing a partial knee replacement? Because the surgery is going to be very minimal and the ligaments and the soft tissues are all preserved here. So the patient can sit in the floor even after a replacement surgery. Sometimes patients can do yoga and all other high-end activities like skiing, running, and everything, because we are retaining all the natural ligaments. Only the damaged part in the inner side of the joint is replaced. Here comes the importance of robotics. Especially in partial knee replacement, robotics is 100% effective, and the future is in the way that rule may come that you should not do partial knee replacement without robotics. That is the safety of robotics, and the efficacy is very, very high. Here is an example of my own patient who had a severely worn right knee and a partially worn left knee, for which I have done a partial knee replacement in the left side. Again, the workflow is like that. The 3D image of the particular affected region is generated by me, and we have to mark some special points inside the knee. Once the data are given to the computer, it will generate a 3D image and it will work up a plan. And I will adjust the size of the implant and the position of the implant everything on the screen before doing the surgery. The first step is to register the data, and the computer will analyze and it will give a 3D model, and I will adjust the position of the implant and analyze the joint tightness. Here this shows the joint is very tight because the graph is below the baseline. Okay, so we need to loosen up the joint to the so that the graph should come above the baseline. How do? We adjust the position of the implant, as well as we do some releases of the soft tissues around the joint. Once I am happy with my plan, and then I will go ahead and do the surgery. Again, a robotic machine will give a color coded region. That means that I need to work on this area alone. I need not go away from this area. Once I bring the tip of the robotic burr near this color coded region, it will get activated and it will remove all the color coded regions. So I don't have to worry about, even I don't have to see the patient at that time. I just have to see the screen alone, and my machine will take off all the damaged bones. Once I do the surgery, and this is the post-operative element. This is the pre-operative X-ray, which shows this is an 8-degree deformity from 180, and this is 11-degree deformity. After the surgery, you could see that's almost 1 degree, nearing close to the 180, the target, and this is absolutely perfect 180 target. And you could see the X-ray being the inner side of the joint and the outer side of the joint are equal, as well as in the partial knee replacement also, you could see the joint space is balanced equally on both sides of the joint, so that you get a perfect alignment of that leg. And what is the recovery of these partial knee patients? See, here's the third day. He had operated on both sides on the same day. On the third day, he is able to walk without any support. And on the third week, he is having a full range of motion, without painless, stable, and very active. So now the patient is a very happy patient, doing all his physical activities, and is happy. A happy patient and a happy doctor. Like sometimes we get crooked limbs like this. The limb is extremely deviated, and the bone is also damaged like this. So how to do, how the robotics helps in such sort of patient? Here the graph shows the joint is completely loose. Here we have to be very, very careful, because if you take too much of bone for such kind of patient, you will end up in a very loose joint. The joint can get dislocated. So having seen a graph like this, the surgeons will be alerted. So we will be very cautious in planning this surgery for this patient. And robotics helps. Here also says what is the level of resection. I am just going to take 0.5 mm instead of the routine 9 mm. For this patient, I am just going to take only 0.5 mm. Okay. So here you could see only one part of the bone is I am going to remove. The other part is completely 0.5 mm only I am going to remove. So this sort of actual data, which is helpful to the surgeon and the patient, are generated by our robotics. So once we do the surgery, we get a balanced graph of leg. Previously, it was a very lax joint. Now it is a completely balanced joint. So we could see the X-ray being the both medial or the inner or the outer sides are equal. Compared to the previous X-ray, that is pre-surgical X-ray, where you could see there is complete loss of gap on the outer side. So here it is restored on both inner and outer side. And what is the recovery of this patient? Is very comfortably walking to and fro, which is a very difficult thing to see in a replaced patient. Again, technology helps in managing a very obese patient. This is the obese patient with a lot of severe damaged knee, and we have operated using this robotics, and see the recovery on the first day. The first day itself, the patient is able to do is completely bend his knee almost 110 degrees. So what is the advantage of robotics? Here we don't cut the muscles, as well as we don't open up the thigh bone, so that the bleeding is less, pain is less, so the patient is able to move the joint immediately. What is the safety? Again, what is the precision of your robotic arms? Here you could see like a model is being tested with the robotic arm. It's the 6 axis of freedom. So the guy is moving the thigh bone away from that, but this it is constantly tracking without any lag. So that is the safety of our safety and precision of our robotics. And there is one automated robo, like, see, which I, the robo which I use, a semi-automated robo where the majority of control will be under my hand and I will be using the tool to remove this. There are some automated robots where they will do all the cuts. Only thing, the surgeon has to do the exposure alone, and the cutting jigs and all will be done by the robots. But still, that is all in the pipeline. But we are still worried about the safety of those fully automated robots. Coming to the cobots, like the collaborative robots, which are used in the spine surgery. So a spine is a very critical area. Like, there are lot of diseases affecting the spine, like disc diseases, fractures, or sometimes tumors, everything. For that, we need to stabilize the spine with the help of our pedicle screws. We need some special screws to stabilize the spine. But passing the screws in the spine is a very dangerous trick, because the margin of error is only 1 or 2 mm only. Here comes our robotic spine assistant. It shows that it will guide us where to pass the screw. So this is a reference tracker which is being placed over your reference spine, and the data is being driven to the robotic spine unit. And with the help of our 3D CM, we will generate a 3D image of our particular patient. And this will allow us to identify what is the abnormal site and what is the size of the spine. For example, see, if you could see, this is a spine model, and you could see 2 large holes on each vertebral body. That is their pedicles, through which we have to pass the screw into the vertebral body. But in between the pedicle, there lies our nervous system. The nerves coming from our brain to our arms and our legs are very closely passing to the inner aspect of these 2 circles. So we have to pass the screw exactly through the center of this pedicle, and there is a high chance that we may break the one part of the circle and we can injure your nerve. So to improve the safety of the system, the robotics helps us in planning the size of the screw, as well as what is the size of the pedicle and what is the angle through which the screw has to be passed. And it gives a real-time feedback about when we pass the screw. Like, it will show us what is the degree of alignment you should have, how much of angulation you should give to your screwdriver, and everything will be guided in real-time manner, so that we can pass the screw in a perfect manner without damaging our neural structures. And with the help of our navigation, it also helps us where to put the incision. Like, it makes a laser cross marking where we can put an incision, and without opening, we can put a screw into the spine without making a big incision. So by means of this technology, we were able to discharge the patient 1 or 2 days after the surgery, because we don't cut open the back. We just pass the screw through the skin itself. That is the help of technology. Right. So coming to the rehabilitative robots, like, let us hear this.
As you can see, my legs are bionic. In 1982, both of my legs were amputated due to tissue damage from frostbite incurred during a mountain climbing accident. At that time, I didn't view my body as broken. I reasoned that a human being can never be broken. I began by developing specialized limbs that allowed me to return to the vertical world of rock and ice climbing. Through technological innovation, I returned to my sport stronger and better. Technology had eliminated my disability and allowed me a new climbing prowess. The bionic limbs that I'm wearing are called Bioms. They've been fitted to nearly 1,000 patients, 400 of which have been US wounded soldiers. We use imaging tools such as MRI to look inside my body to figure out the geometries and locations of various tissues. Here's a 14 actuator circle that goes around the biological limb. The actuators come in, find the surface of a limb, measure its unloaded shape, and then they push on the tissues to measure tissue compliances at each anatomical point. Across my residual limb are electrodes that measure the electrical pulse of my muscles that's communicated to the bionic limb. So when I think about moving my phantom limb, the robot tracks those movement desires. This video shows Lisa Millette shortly after being fitted with 2 bionic limbs. Indeed, Bionics is making a profound difference in people's lives.
Oh my God, I can't believe it. It's just like I've got a real leg.
Don't start running.
Now turn around and do the same thing walking up. Walk up, get on your heel to toe, like we normally just walk on level ground, try to walk right up the hill.
Oh my God.
Pushing you up.
Yes, I'm not even, I can't even describe it.
As you can see,
Okay. So having seen that video, it is really interesting to see such developments, because we have seen patients who have lost their limbs due to accidents or due to any vessel disease, or it could be due to infections, diabetes and everything. But those patients, when we ask them to rehabilitate, they are not able to do because of weakness of their bodies and their limbs, as well as many of them are obese. But this sort of bionic limbs, which is going to help them in a bigger way, because they are going to get feedback from the whatever muscles which are remaining. That remaining muscles will be activated by the patient's brain, and these muscles will send a signal to the artificial limb around the ankle and foot, and it will push up the individual to the next height. So definitely bionics is going to take up a very big lead in the coming years. To summarize, like surgical robots are semi-active with haptic feedback control, or a fully active autonomous robots such as Robotic, or a collaborative robots called cobots, which we use in spine surgeries, as well as rehabilitative robots like Bionic. But there are a lot of movies or science fictions regarding the man versus robot war. But always in a discussion between man versus robot, what I feel is a firm, good handshake is the key to survive. And I thank one and all for your patient hearing, and also I thank Dr. Vimla and the team, SRM, for giving me this opportunity. And I hope I was clear and loud. Thank you. Thank you.